All right, we'll get started this afternoon, morning, or evening, depending on where you're from, team. Welcome to another episode of the Australasian Pleural Seminars. Thank you for joining us from around the world. We really are excited to keep this series exciting and bring new topics as it pertains to pleural disease. Today, I have the privilege and honor to introduce Dr. Carolyn McIntyre. She hails from Canada, my part of the country where I came from as well. So she did her training at the University of Alberta, doing her master's and PhD in the Faculty of Physical Education, and came to Australia in 2011, so a few years before me. She came to do her postdoctoral fellowship in the Exercise Medicine Research Institute, and in 2015 was awarded a Cancer Council postdoctoral fellowship in the setting of exercise as a therapeutic tool in the management of mesothelioma, working with none other than Gary Lee, and has been kind of with us ever since, for better or worse, maybe worse for her, but better for us. She's been very successful in her career, publishing over 75 peer-reviewed publications and securing over $1.7 million in competitive funding to run a lot of these amazing studies. So I have the privilege, again, like I said, of introducing her, and she's joining us today to discuss exercise and diet for patients with malignant pleural effusion, which is very topical and important for our patients. So without further ado, I'll turn the screen and mic over to her, and let's get started on her talk.
All right, thank you for that very kind introduction, Dhaval. I'm gonna share the screen now. Thing working? All right, so I'm delighted to be here at TAPS today. Thanks for having me. And yeah, I'm going to be talking about exercise and diet for patients with malignant pleural effusion, with the caveat that I'm not a dietitian. So we have the privilege at Charlie's of doing research with a fantastic dietitian. And so she's helped me out with that part of my presentation, thankfully. Okay. So the first position statement on exercise and cancer came out in about 2010. And since then, there's been many organizations that have released guidelines supporting the benefits of exercise in a variety of cancer populations and different cancer settings, primarily during and following treatment. And of course, guidelines are really important for developing and promoting an evidence base. And hopefully at this point, we can all agree that exercise is likely beneficial for cancer patients and survivors. And in fact, we did a survey in our group last year and found that 94% of Australian healthcare providers working with cancer patients agreed that exercise is beneficial. However, of course, the challenge with that is that guidelines are quite generic. And particularly when we think about a heterogeneous population like malignant pleural effusion, particularly that it's an advanced disease and it can progress quite quickly. Not all exercise is created equal. So we have different types of exercise that can have a very different effect. So when we're thinking about exercise in the setting of malignant pleural effusion, I think it's really important to think carefully about what our target is, what we really want to change, and what exercise prescription can address this. Because as we see here, we've got resistance training, which is primarily targeting muscle mass. We've got some physical activity outside, and then some aerobic training. And all of those are really important, but they all have very different effects. And so it's important to take a targeted approach. So today, I'm going to talk about the case for really resistance training for patients with malignant pleural effusion and the role that diet can play in that. We know that these patients have a very high burden of things like pain and fatigue and shortness of breath, and some subsets will have some specific psychological concerns as well. And as Gary always tells me, these patients can tend to waste away so challenges with weight loss and anorexia are common and distressing symptoms. So I'm going to focus on some research around sarcopenia and malnutrition, with, of course, the caveat that I'm not a dietitian, and what these impacts can have in a population like malignant pleural effusion. So in the oncology setting, sarcopenia is typically defined as low skeletal muscle mass. Now, there is a lot of debate in the field about how we measure that, how we define it, and what the cut points are. But a lot of the research really comes down to sarcopenia being low muscle mass in the arms and legs. And so what we see here is a cross-section of the mid-thigh. And in this picture, we can see that we have a good amount of muscle. Let me get my pointer working. Oh, maybe So we can see that we have a good amount of muscle, we have some adipose tissue, and importantly, we don't see a lot of fatty infiltration into the muscle, which is great. So we have sort of our 40-year-old triathlete here. Now, unfortunately, what we see here is an example of primary sarcopenia, so sarcopenia due to aging. And what we have is a much higher amount of adipose or fat tissue, a smaller amount of muscle mass, and a lot of fatty infiltration into the muscle here. Now, the good news for all of us is that all is not lost. And if we continue exercise training and being active and we have some lucky genetics, then we can also look like this 70-year-old triathlete, hopefully, who has, again, a small amount of adipose tissue, a really nice, large amount of high quality muscle mass. And I guess the question we think about today is sort of what happens if you get this 74-year-old patient showing up in your clinic with, let's say, a malignant pleural effusion secondary to lung cancer. So in malignant pleural effusion, we can see skeletal muscle mass itself can be due to not only age, of course, it's important for aging and sedentary being inactive, but sarcopenia can also be due to the cancer itself. So we know cancer is really metabolically active and can result in loss of muscle. There is some evidence, particularly in mesothelioma, that cancer treatments can also contribute to muscle loss. So high proportions of patients with malignant pleural mesothelioma have been shown to lose muscle mass during chemotherapy treatment. Of course, weight loss and malnutrition contribute to skeletal muscle loss, and these are all compounded by inactivity. And what are really the implications of that then in malignant pleural effusion? Well, we see some good evidence that patients with sarcopenia have decreased quality of life and physical functioning. And I think this is particularly important when we think about this patient population that sort of has that sort of maybe 9 to 12 months of survival, that the ability to, get up and down out of a chair, to play with their grandkids, get out to do, and those aspects of physical functioning are actually really important. There's some evidence that patients with sarcopenia have a higher symptom burden and a higher length of hospital stay for people with malignant pleural effusion. Our group has done some work on physical activity, and we've shown in a couple of studies that patients that are sarcopenic are less physically active than those that are not sarcopenic. And so that's light activity. So that's sort of activities of daily living. So that gives us some insight into the fact that these patients are less able to do those day-to-day activities. In other cancer populations, and in particular treatments, we see that patients that are sarcopenic have a higher risk of treatment toxicity. And there is some really preliminary evidence that muscle loss could be associated with reduced survival. So our group has shown, as well as some others in mesothelioma and in lung cancer with malignant pleural effusion, that those with muscle loss do have reduced survival. But I think I just want to make the point that people with sarcopenia, it's not necessarily the patients that you would expect. So we've done a series of studies looking to really characterize malignant pleural effusion and pleural mesothelioma patients in terms of their muscle mass and activity levels and nutritional profile. And in this study, this was just over 60 patients. And what we saw was that over half were sarcopenic, so 54% were sarcopenic, and 40% had malnutrition. Now, importantly, in this group, a very high percentage, so 92% had an ECOG status of 0 or 1, so had a good ECOG performance status. The average body mass index was 26 or overweight. There were no underweight patients in this profile, and on average, patients were 2 months from diagnosis. So what this tells us that even patients that are early in their diagnosis and maybe a normal or overweight with a good performance status can still have sarcopenia and malnutrition. Now, the Clinical Oncology Society of Australia, we know that sarcopenia and malnutrition are common, so there are some screening guidelines that can help us. Of course, I guess it depends on what healthcare system you're in. I know certainly in Australia, not many patients have access to a routine DEXA scan or a CT scan that can be analyzed for sarcopenia. We do have some screening tools that can be used. So this QR code takes you to the malnutrition screening tool and the SARC-F, which are questionnaires that can be used. And COSA recommends that patients are screened for malnutrition and sarcopenia and at diagnosis, and then repeated as the clinical situation changes. So that's one option if you're looking to identify patients with sarcopenia or malnutrition in your clinical practice. And so if we know that there's a very high proportion of these patients, and if, let's say, we are able to identify who they are, then what can we do about it? I'm going to present a little bit of data on an individualized exercise prescription that we did for these patients and about the role that individualized medical nutrition therapy should play for this patient group. So in the pleural medicine unit at Sir Charles Gairdner Hospital here in WA, we did an exercise intervention that was really targeted supervised resistance exercise. We wanted to be short. This was in patients with malignant pleural effusion. And so we wanted to be a short 6-week intervention, so ideally 18 sessions. These patients had an optional 2-week makeup period. So for some people, it did take 8 weeks for them to complete the sessions. In exercise prescription, we often talk about the FIT principle, so frequency, intensity, and type of exercise and time. So the frequency was 3 sessions a week, ideally. The intensity was moderate to high intensity. The type of this targeted only resistance exercise, so there was no aerobic training component. And we did that because we really wanted to focus on muscle. And we also thought that for these patients with their burden of fatigue and shortness of breath, that resistance exercise might be more feasible for this group. And we did exercises that targeted the muscles of the lower and the upper body. Now, I've talked about how this is a really heterogeneous group, and we know that these patients present with differing performance statuses and different things like symptoms and things, and that those can change over time. So how did we individualize this exercise to make it feasible for this group? We used a concept called autoregulation within the program. So autoregulatory progressive resistance exercise is a method that's used in athletes where exercise training is progressed at their own pace, and it's changed based on these daily and weekly variations in performance. So this is quite intuitive for patients with malignant pleural effusion, because we know that over time, they're going to have times when there's high physiological stress and psychological strain, and there'll be times when that gets better. So it might be that during treatment or when the effusion is occurring fluid or things like that, it's high. But we also generally know that this is going to increase over time with disease. So over the time with disease, we expect that symptom burden, psychological strain, and physiological stress is going to be going up. So we want to think about readiness to train based on a person's kind of their good days and their bad days, depending on how they're feeling and what their symptoms level are. And what we essentially did was think about readiness to train. So if we look at this, for instance, right here, we see a high psychological strain, a high physiological stress. So maybe this patient's on treatment, or maybe they're having an exacerbation, or they're feeling high shortness of breath and fatigue. So they might have a low readiness to train on that day. Whereas at another time, maybe someone's finished their treatment, their physiological stress is low, their psychological strain is low, and they might have a high readiness to train on that day. So we want to modify the exercise stimulus so that when people have a low readiness to train, we might adjust their prescription and make it a bit easier. And when they have a high readiness to train, we might make their exercise prescription a little bit harder. Now, I did tell Gary I was going to call him out a little bit on this slide, because the first time I presented this and he saw it, he said, oh, well, this doesn't make any sense. If I don't feel like exercise training, I'll just stay home then. That's what that's telling me. And I mustn't have explained it very well, because I think it means the exact opposite, actually, that we really want to encourage people that even when you're feeling unwell, there might be some exercise that you can achieve, and that we can make adjustments to make it achievable. So how hard the exercise feels might not be that different between these 2 days. It's just the stimulus will be different based on how they're feeling. Now, how did we achieve this? Well, we had patients when they came and we asked them a series of questions about how they were feeling on that day. So we asked about common side effects like pain and shortness of breath and fatigue, or any new symptoms that they've experienced. And so this was really, we wanted to operationalize autoregulation by opening up lines of communication to then make some adjustments. And so from there, we would make some changes to the exercise prescription. So if the target was, say, 2 sets of 12 repetitions, and patients came in there are feeling really good, we might increase the intensity depending on how they're going, or we could increase the volume, or we could increase the rest periods. Alternatively, if they came in and they were feeling quite tired and fatigued, we might decrease the intensity by reducing the amount of weight they're lifting. We might decrease the volume and say, okay, you know what, we're just going to do 1 set of everything today. Or we could increase the rest period. So say, okay, we're going to take 2 minutes of rest between all of our sets today. Or you can even add little micro breaks within a set. So if people are really short of breath or really fatigued, we say, okay, we're going to do 2 reps, take a 5-second break, another 2 reps, a 5-second break. So there's different ways that we can configure exercise to make that more feasible. Now, look, this worked really well for some participants, and there's things that you have to consider as well. So some people really never want to drop their weight. So they've reached an amount of weight that they're lifting and they want to keep that up. So you have to think about patient preference when you're making these adjustments. And also there are some patients that, don't really want to, they weren't great every single day. They rated their pain and fatigue and shortness of breath the same. So look, it's not perfect, but I think it's one way that we can think about adjusting exercise to make it feasible for these patients to exercise when they come into the gym, even when they're not feeling very well. So we found following our 6-week intervention that there were significant improvements in functional capacity. So we measured this walk test. And remember that this was only resistance exercise, and we had almost a 60-meter change, which reached the threshold for what we would consider clinically meaningful in lung cancer patients anyway. When we look at our changes in muscle mass, at baseline, about 54% of our group were sarcopenic, which we would expect. And by the end of our intervention, this had declined to 27%. So we did have a significant improvement in the lean mass in the arms and legs, and this resulted in a reduction in the percent of patients that were sarcopenic. Now, importantly, our dietitian was quite interested in what the effective dietary intake might be on this. So she actually measured whether participants had adequate protein and energy intake at baseline and post-intervention. And then we categorized, so if they had adequate at both baseline and post, we considered them adequate, and if they had inadequate at either of those, they were considered inadequate. And what we found was that about half, just over half, did not have adequate dietary intake and subsequently did not have a change in lean mass. The participants that did have adequate protein and energy intake did have a significant improvement in lean mass. Now, of course, this isn't rocket science. It makes sense that patients that don't have adequate intake won't be able to put on lean mass. And I just think it really highlights the importance of having a dietitian on the team. And really moving forward, we've incorporated dietetics in our interventions with the idea that we need to take a multi-pronged approach to address reductions and loss of lean mass. Now, also interestingly, in this population, of those that did not have adequate dietary intake, there were a portion that was because they were unwell or experiencing symptoms, but there was also a proportion of patients that had voluntarily restrictive diets, so had changed their diet in some way to, say, reduce sugar or reduce carbohydrates, other things, since their cancer diagnosis. And so it's important to be able to be flexible around those diets and still counsel patients to meet adequate protein and energy intake. So our dietitian here, Dr. Emily Jeffrey, has produced a couple of flyers that are tips for eating well for the for NCARD here in WA. And when I spoke to her, she said, look, the most important thing is to provide evidence-based advice, which really comes down to targeted healthy eating advice. And Emily, we're doing an intervention now where she's done targeted telephone dietary intervention in about 40 patients now from the intervention group. And so, this is really about focusing on high energy and high protein advice, and that really needs special skills and the ability to be considerate of restrictive diets that participants might be choosing to take part in, and how we can support those people to still meet their energy and protein intake. Her top tips for people with poor appetite was eating smaller snacks and more regularly throughout the day. Eating the foods that you enjoy at any time of day. So who doesn't like breakfast for dinner, right? So whatever participants feel like eating, whenever is the best time, that's fine. And to plan the largest meals for the time of the day when individuals have the best appetite. For those with difficulty breathing, advice is to do things like rest before meals and focus on having soft foods and nourishing drinks. For those that are fatigued, there's a lot of options these days in pre-prepared food, and really encourage people to ask for help where possible or look for services for meal preps. And most importantly, I think, is to share weight loss or symptoms that are impacting, so any nutritional impact symptoms, with a doctor to seek referral if needed, because certainly there is really good support available for those that can work with a dietitian. So look, to sum everything up, if we think of our physical reserve capacity and our musculoskeletal fitness across our lifespan, unfortunately it kind of peaks in our 20s and 30s, and then there is this gradual decline. But how quickly and how steeply this decline happens comes down a lot to our exercise and activity habits. And so when we think of patients with malignant pleural effusion, we've done some longitudinal data, and certainly there are some individuals that can drop off very quickly in their musculoskeletal fitness. What we see more commonly in our research is that people will decline and level out and decline and increase and decline and increase, but still have this overall downward trajectory. And so what we hope is that by using appropriately prescribed resistance, exercise, and nutritional therapy guided by an accredited practicing dietitian, that we can offset this, because really we want to keep participants out of the sarcopenia, toxicity, and disability area. And by using those things at our disposal, we can hopefully keep people as well and active as possible for as long as possible in their disease course. So in conclusion, in malignant pleural effusion, we do have high rates of sarcopenia and malnutrition, and it's not always in the participants that we expect, and it's probably in patients with a normal BMI or overweight. Screening and referral to appropriate services for dietetics and exercise or physiotherapy can be a good way to help participants maintain their muscle mass and physical activity levels. And that one thing to focus on, particularly around muscle mass, is targeted resistance exercise and nutritional therapy. All right, so that is all from me, Dhaval. Will I stop sharing this screen?
Yeah, no, that's perfect. Thank you so much, Carolyn. That was a brilliant and just such an important topic. Similarly, my other world outside of Pleural, but still within the lung space. So with lung cancer, this is one thing I tell my clinic patients all the time is, listen, you have a terrible diagnosis, right? Or, terrifying diagnosis. But the three things you can control are good exercise, good sleep, and good nutrition, right? So it's such an important thing that's been kind of overlooked and overshadowed by, the big cancer diagnosis and frequently a lot of the symptoms that people feel. But it's such an important aspect. And even, within like lung cancer, we're doing prehabilitation. So patients that we think are going to be surgical patients, we're getting them to do exercise even a few weeks before. And we know that makes a difference. So such an important topic to kind of understand, digest, and then offer our patients appropriate screening and offering the appropriate referrals to dietitians, exercise physiologists, and all that. So thank you so much for sharing that. I will open up the chat to anybody who has questions. Please put them in the chat, and I'll start going through them shortly. But in the meantime, I'll start by asking, some of the questions that I think are very interesting. So, that one of that last graph that you showed with the resistance exercise and such,
Yeah.
It's very kind of interesting because it kind of looks almost exactly like the Fletcher-Peto curve for pulmonary function loss that we've known since the 1970s. So, and it kind of drops off right at the same time in terms of age. So around 30, we start losing lung function. I teach my patients that all the time, my COPD patients, in attempts to help them understand and quit, is that so if you stop smoking, you'll never go back to normal, but you will improve and you'll stop dropping down at that same decline, right? So it's very interesting to see the lung function curve and the exercise curve, which, I mean, it makes kind of sense. Lungs are related to exercise physiology, but just thoughts on that, perhaps?
Oh, yeah, look, I think it is really interesting. And that idea that, of course, we're not, you might be able to maintain sort of where you were in your 30s for a little while, but there is going to be that gradual decline. But certainly that rate of decline is way more in our control than I think people realize. And of course, there's some genetics involved in that, right? And how high you can get and how quickly you decline will certainly be affected by that. But yeah, I think it probably plays true across lots of different aspects of our physiology, right? That we might peak, but how much we decline and how quickly we decline comes down to the choices we make with our health and things. So yeah, and I think that comes back to like the idea of this autonomy too. We were talking about earlier about patients choosing to exercise and choosing to, it's something people can control. So sometimes the aging process can feel really out of our control. I'm certainly having my mid-40s now. I feel like, oh no. But there's absolutely things we can do to make that process more smooth and more. I never really thought about that before, Dhaval, to be honest, about the how similar it is to pulmonary function. But yeah, certainly.
Absolutely. And so the other question then is that, so this, can be quite resource intensive, or even for patients getting out there for pulmonary rehab is kind of the other equivalent I look at, from the chronic lung disease world, is that, frequently patients would say, by the time I get to the location and get to where I need to go, especially in the hospital setting, they're just, they're just pooped. They have nothing left in them, right? And even just getting to the location sometimes can be challenging for them. So, obviously it's very important to have extra, the supervision and all that kind of process that you should. We can kind of, on a bad day, we can change things for them and help them understand it's still important to do something, whatever it is, and change the regimen. But in terms of patients, especially in WA being a huge state, for our rural patients, any thoughts on tele kind of rehab and tele? Is there something that's a program out there available or something worked on?
Yeah, look, I think there are lots of options for telehealth. I know for supervised programs within the metro area, Cancer Council has some great programs that are free, that people can come and they get an assessment at the beginning and the end. That's here in WA. At the Exercise Medicine Research Institute, we, since COVID, everyone's moved into a lot more telehealth, and we have a fantastic setup. And we run even group programs specifically even for people with bone metastases. So you'll get, 8 people in, one exercise physiologist. So it's much more cost effective and it's much more accessible for people. And so we've done that in a wide range of cancer patients. We've done a little bit in lung, but advanced ovarian cancer, lots of different groups. And it is really effective because you get people in their space and it shows them how they can continue to exercise as well on their own. Because I think a lot of these concepts of autoregulation, they're intuitive to patients. It's just actually helping them work through those things. So the idea being at the end of the intervention, they can figure out for themselves, okay, when do I increase my weight? When do I decrease it? What can I do to make those changes? And so, yeah, I think telehealth, especially in a place like WA, is really critical, essentially. And I mean, what we found with that exercise intervention, 3 of the people that dropped out essentially couldn't access easily the exercise program. So, they're going in, they have to go upstairs. And so people with oxygen, that's really hard. And the elevator was out. And, so yeah, I completely agree that we need to have options for people that are in their own community and in their own space. And telehealth is a great option for that.
Mm-hmm. That's brilliant. And then, so the other thing was, what was fascinating to me is you showed some of the pictures earlier on with the 40-year-old triathlete and then, the patient, the 70-year-old triathlete. It was amazing how much, I couldn't tell, looking at it face value. So it was quite impressive to me how much change can happen with that exercise. So, I think we need to turn that into big posters and just put that all over billboards. I think it's people underestimate how much, I've always in my ICU days, I would tell patients, 1 day in the ICU is 1 week of rehab easily, just because of the muscle mass that we lose with, and we know that in diaphragm muscles, when patients are intubated, we see significant loss within 48 hours. So it's so impressive to see that, at a systemic full body level, looking at thigh muscles essentially, right?
Yeah. I think you're totally right. Bed rest is really hard on all of your systems and particularly on muscle. Even cardiovascular fitness, right? If you've seen those NASA studies where they essentially make people lie down and not move and what happens over time, and you're losing like a significant percent of your fitness every day that you're just lying in these bed rests. So yeah, and just the notion that you can maintain your muscle mass over time, I think is really important.
Absolutely. So I got some questions here. So we said, find that patients need to be able to walk a minimum distance of approximately 200 meters to attend an outpatient pulmonary rehab program. What was the mean distance that your patients achieved on 6-minute walk test pre and post intervention?
Ooh, good question. Give me a second and I will find out. I don't want to give you the wrong information. It was over 200 meters, certainly. Look, sorry, it might take me just a second to find that.
That's all right. Yeah, but I think these are the kind of important questions. It's just, that overall capacity. I think sometimes we look at FEV1s and all sorts of other quantitative measures, and 6-minute walk, I think, is probably one of the best because it just really let's just see what you can do, right?
Absolutely. And it's doable, right? Like we can have people come in and you don't need that much space and you don't need that much time to do it.
That's right.
I'm really sorry. I can't seem to see that at the moment. Look, I want to say it was around 350 that patients got at baseline. So yeah, they were, able to do and able to get there, certainly. And we had an improvement of about 50 meters-ish, something like that, 60 meters, following the intervention. Yeah.
Mm-hmm. Very well. And then just before we finish up, I want to be cognizant of time. Just one question is, and this kind of always relates to what I like to ask at the end, and kind of 2025, what would you recommend kind of thing, when this ties into it, but what are the baseline investigations that we can do in clinics as frontline, when we see the patients?
Yeah, look, I think in clinic we don't have great screening tools for sarcopenia unless we're using DEXAs and things like that. I think that SARC-F that I put up, it's a 5-question thing, and the MST is a malnutrition screening tool, is a really good screening tool that we can use to just quickly. It's 3 questions, and it just gives some indication whether a referral is needed or not. So that's a really good one to use. We use the patient-generated subjective global assessment, excellent assessment, but it's a little bit more labor intensive, I would say. I think the 6-minute walk test is a great test for looking at functional capacity, but even things like repeated chair rise. So at the end of the day, if a patient can't get out of a chair and do things, it doesn't matter how far they can walk or whatever. So that's if we're looking at muscular strength and changes over time, I think the repeated chair rise test. Even just, I think we did a 5 repeated chair rise test in that study. I didn't present those results today. I was just keeping it quick, but we found significant improvements in that as well over the course of the intervention. So I think it was maybe, I can't remember, sorry, off the top of my head what our change was there, but So yeah, I think those kinds of really functional tests that have a meaning to patients, I think people can understand, yeah, I need to be able to get up out of a chair and ideally unassisted, and how can we improve that? And you can get really good improvements in those things early on. So I mean, most of the changes we would have seen in this study would be neural changes. So those being able to use muscles well and working together well is really important. So yeah, does that answer the question? Sorry, I started talking and then a bit off
No, no,
track
that does.
maybe.
Yeah, no, I think you hit on the topics. Yeah. So that's brilliant. So I'm cognizant of time, but Carolyn, thank you so much for enlightening us about exercise and diet and giving us some of those great pictures and graphs. That was really kind of eye-opening, and hopefully our audience and our colleagues around that have logged in has been helpful for them as well. What I will end with is to remember that we do record these sessions on YouTube. So please, if you've missed it or wanted to recap, follow up on YouTube, and you can rewatch the videos whenever you want. And as this will be the last session for the year, I just want to thank everybody for tuning in and really supporting this and making this a great exchange of information. We're so excited to have amazing speakers like Carolyn and everybody that we had this year to really just come together as a group and as colleagues around the world to really educate ourselves and help each other out and really achieving the best for our patients. So thank you again. Have a great holiday season, and we are excited to catch up for the new year and get started all over again.
Thanks so much for having me. Thanks, everyone.
Absolutely. Take care, everyone. Thank you for joining.